Hello guys. So now let us start hematology. Okay. So first, before starting about the pathologies of hematology, let us start with physiology of all these RBCs, platelets, and WBCs, and then we'll go on to the respective pathologies of these RBC, platelets, and WBCs. Okay. So let us start with hematopoiesis. Like how does this get produced? Okay, so RBCs are produced by erythroblasts. See, all of these three things will be produced by progenitor cells. Okay, progenitor cells are the primary thing. So progenitor cells will give rise to erythroblast, which will form reticulocyte, and then RBCs will be formed. This is how RBCs will be formed. Okay, RBCs have 120 days of lifespan. Then coming to platelets, again progenitor cells will give rise to megakaryoplasts, which will give rise to megakaryocytes. Okay, so megakaryocytes are nothing but platelets. Okay, then coming to WBC cells, there are two types. One is myeloblasts, then other one is monoblasts, then lymphocytes. Okay, so in WBCs, the myeloblast will give rise to eosinophils, basophils, and neutrophils. Okay, so what are the functions of these eosinophils, basophils, and neutrophils? Is in allergies, mainly we can see eosinophilia, right? So IgE and all these things, and eosinophil rise will be there in when we see an increased amount of allergies and all these things, we'll suspect eosinophilia. Okay, then coming to B, that is basophils, it is going to be increased in CML. Okay, we'll come to CML, what is CML and all, we'll be discussing now only. So remember, basophils will be increased in CML. Okay, then coming to neutrophils, it will be raised in infections. Okay, in bacterial infections and all, neutrophils will be raised. Then coming to monoblasts, monocytes will give rise to macrophages. Okay, these are the largest WBCs. Okay, so these engulf the pathogens. Okay, so these are the two types of WBCs. Then coming to lymphocytes, it is gonna give rise to lymphoblasts. These are the immature cells which give rise to three types of cells. Okay, not two, there are three types of cell. One is B cells, another one is T cell, then the natural killer cell. Okay, B cell have two types. One is antigen presenting cell, the other one is immunoglobulins. Okay, then T cells also has two types, that is T helper cells and T cytotoxic cells. Okay, so when we move on further with the general hematology chapter, you'll get to be familiar with all these things. Okay, for now you remember that hematopoiesis is happening, and these are all the cells that we'll get to see. Okay, then these all the WBCs, RBCs, and all these things will have something known as CD markers. Okay, what are the CD markers? CD markers are nothing but ID cards. Okay, so we have given ID cards for all of these cells, and whenever the increase or decrease is there, we'll get to see these CD markers to be increased or decreased in our body. Okay, so that is why we have given ID cards. See, for example, we know we all have been given certain names. Okay, but still in our colleges and schools we'll be given roll numbers, right? Roll numbers and registration numbers. So in the same way, scientists have given these cells certain ID numbers, so that is known as CD markers. Okay, that's it. Okay, this is the easier way you can know what the CD marker is. Okay, then so now that you know how the hematopoiesis happens, so let us go on one by one. What are the physiological functions of these RBCs, platelets, and WBC? Okay, starting from RBC. So how so RBC's main function is to deliver oxygen, right? So RBC is there, globin is there, heme will be there, heme will be the center, and globin structure will be there, that is alpha and beta chains will be there. So these carry hemoglobin, right? Hemoglobin will be there. So all these hemoglobin will carry one oxygen. Okay, oxygen molecule. So this will give to the tissues when oxygen is required. ATP is required. It requires aerobic, that we discussed in biochemistry, right? Aerobic metabolism, glycolysis and all this will happen. So ATP is required, meaning to produce energy we require aerobic environment. So that is why oxygen will be provided. So this is what is the need of oxygen in our body. Okay, so RBCs require heme, right? RBCs require heme to deliver this oxygen. Okay, oxygen will be binded to heme. So that is why RBC requires heme. So let us see how the heme enters our body and how is heme transferred into our RBCs. Okay. So the dietary iron that we eat, right? We were discussing there are the macronutrients and micronutrients we discussed in biochemistry. So these micronutrients, one of the major micronutrient is minerals, right? Vitamins and minerals. In minerals, iron is one of the major micronutrient that we require. So the dietary iron that we eat is in Fe+3 form. Okay, what happens is in intestine there is something known as DMT1. Okay, DMT1 channel is there. What it does is it converts Fe3 plus into Fe2 plus. Okay, this DMT1 and intestinal enzymes convert this Fe3 plus into Fe2 plus. Then again this DMT1 will take the Fe2 plus inside the enterocyte and will convert into Fe+3 form. Okay, so during this process then it will go on inside the blood. Okay, so Fe3 again in Fe3 plus form only this will be transferred into the blood. Okay, so during this conversion the enterocyte will have something known as ferroportin 1. Okay, so ferroportin 1 will be in the enterocyte. Okay, so this is what will regulate how much amount of iron should be absorbed or how much amount of iron should be not absorbed. Okay, so this is the channel that that decides how much amount of iron should be absorbed. Okay, this channel is controlled by something known as hepcidin. Okay, so hepcidin has a negative feedback on ferroportin. Okay, so now wait, let me come back to hepcidin. But see, now Fe3 plus has been absorbed and it has gone into the blood. So from blood, all this iron that we absorbed will go into liver and to marrow. We'll come back to marrow. For now, you see liver. Okay, so liver will start storing enough iron. Okay, so when enough iron is there, the hepcidin will have a negative feedback on ferroportin 1. Okay, so now the ferroportin 1 channel will end its activity. So that is how we will not be absorbing iron. Okay, this is what happens. Okay, if there is a defect in hepcidin, that is when we'll get a pathology called hemochromatosis. Okay, hemochromatosis happens because there is defect in hepcidin activity. So that is when there is no negative feedback for ferroportin and increased amount of iron absorption is seen, and all this iron starts getting stored in our liver and our body. That is when we call it as hemochromatosis. Okay, now coming back to marrow. So blood was going to liver and marrow. So in marrow, all these cascade reactions will take place where the iron will be incorporated into ferrochelatase and there is a cascade of reaction and it will be incorporated into protoporphyrin, finally leading to formation of heme. Okay, remember lead. Okay, lead that is in all the paint and etc. So paint. Okay, so whoever the painters are there, we can see this heme deficiency. Okay, paint has increased amount of lead, so that is why lead is inhibitory for ferrochelatase. Okay, so lead is inhibitor for heme formation. Okay, heme synthesis inhibitor is lead. Okay, so that is why we should be careful in suspecting anemia in a painter and all. Okay, so whoever is has high exposure, occupational exposure to lead and all, so we should be aware of it. Okay, so this is how heme is formed, and this heme will be incorporated into RBC, and finally the hemoglobin will carry the oxygen to the tissues. Okay, this is the function of RBC. Now let us come to platelets. Okay, so platelets are the ones that are required for coagulation. What is coagulation? So somewhere the bleeding is happening, so we are supposed to form a plug to this is like a tape. Okay, so a tape to reduce the bleeding. Okay, so this is the main function of platelet, right? So this is the main function of platelet. Okay, so this is also called as hemostasis. Blood is flowing. To stop it, it is known as hemostasis. Hemostasis happens in two different cycles. One is primary hemostasis and another one is secondary hemostasis. Primary hemostasis is also known as temporary plug formation, where during a damage the temporary plug is formed by these platelets. Okay, around these platelets a temporary tape is being formed. Okay, so to reduce the hemorrhage that is happening. Okay, so let us see how it happens. So suppose there is an injury to the blood vessel. Okay, so now there is a opening here, right? So what happens is the injured endothelium will secrete will have a WP bodies. Okay, so WP bodies will be there. This WP bodies start secreting something known as von Willebrand factor. Okay, von Willebrand factor. Okay, so please remember these two things. WP bodies is what releases the von Willebrand factor. So when after the release of von Willebrand factor, so the random platelets start attaching to the GP1B of the injured site. Okay, so there is GP1B receptor near the injured site. Okay, so at this injured site, these platelets that are in the blood vessel, all these platelets will be going, right? So when this Waldman factor starts showing up the GP1B factor, all these platelets, oh okay, receptor is there, they'll start attaching to this receptor. Okay, then the other random platelets were there, right? So one of the platelets attached here, many of the platelets start attaching. Okay, so then what happens, the other roaming platelets were there, right? So the other roaming platelets, what happens is they see that these platelets are attaching somewhere. Okay, then what they do is the already attached platelet is there, no? So what it does is after attaching to GP1B, it expresses another receptor on their platelets called ADP or P2Y1 receptor. Okay, this is called P2Y1 receptor. Okay, this is what the platelet already attached to the endothelium will start expressing. Okay, then this calls the other platelets to start attaching to it. Okay, so once this P2Y1 receptor starts expressing itself, now what happens is the ADP that is already present in the blood start attaching to this particular receptor and generates another receptor in the platelet that is known as GP2B. GP1B was from endothelium, 1B was from endothelium, whereas GP2B is from platelets. Okay, so at GP2B site, the other platelets that were roaming start attaching. Okay, so start attaching in a cascade manner. Okay, so this GP2B will allow other platelets to aggregate. Okay, how will it aggregate? It requires fibrinogen. So it requires fibrinogen. A molecule called fibrinogen will go and attach to this site and the other platelets will go and attach to the GP2B site and start forming a cascade. Okay, so all these things will start attaching and form a plug. Okay, so blood cannot leak out from that particular damaged phase. This is known as primary hemostasis. Okay, then what happens is after attaching of the fibrinogen, then there occurs another cascade of reaction where arachidonic acid starts secreting COX. Okay, so when the COX is released, there is thromboxane A2 generation in that particular platelet and plug formation will start happening. Okay, this is the entire reaction of primary hemostasis that you should be aware of. Okay, that's it. Then after formation of primary hemostasis, there is secondary hemostasis. Before going to secondary hemostasis, let us see what happens if there are problems in these particular steps. Okay, see, I told you, right, WP bodies release something known as von Willebrand factor. Suppose if von Willebrand factor release is not there, it is called as von Willebrand disease. Okay, this is one of the major hemological disorder. Okay, then coming to GP1B, I told you, right, endothelium will start showing up the GP1B receptor on itself, where the platelet starts binding first. Okay, so if that GP1B receptor is affected, then it is known as Bernard-Solier syndrome. Okay, then one more thing I want you guys to remember is the drugs that we use as anticoagulants, where these drugs will start acting on. Okay, in ADP2Y1 receptor, it is clopidogrel, prasugrel, and ticagrelor are the drugs that these drugs will act on in P2Y1 receptors. Okay, this is where we use in myocardial infarction and anticoagulants, right? Oral anticoagulants that we use. This is where it will go and bind to it and doesn't allow the other platelets to form the plug, so that there won't be thrombus or emboli formation. Okay, this is how we prevent it. Then abiximab is what prevents GP2B to bind the platelets on. Okay, so GP2B receptor function will be affected by abiximab. Okay, see, so in each level we are targeting and preventing the coagulation to be occurring. Okay, so this is how we use the drugs. Then again, I told you, right, after fibrinogen attachment there is a cascade of reaction. The COX inhibitor is aspirin. So we use aspirin also, right, in MI to prevent thrombosis and increased formation of thrombus or emboli. To reduce the more complication, we use aspirin, right? So this is where we are preventing the cascade of formation of platelets. Okay, so platelet clubbing is there, so to prevent, so the artery is getting blocked, so that is why we are preventing this by giving aspirin. Okay, so that the blood can flow easily. So these are the steps where we attack the coagulation pathway. So this is with respect to primary hemostasis. Now coming to secondary hemostasis, this is a temporary plug. Okay, this is not a permanent solution for a hemorrhage that is happening inside the vessels. Okay, so next is secondary hemostasis, where there is coagulation factors in our blood. Okay, these are the proteins. What they do is they undergo a cascade of reaction and form a permanent plaster. Okay, this was a small plaster just before the plumber comes. No, just I have stopped the water from leaking. Okay, that is primary hemostasis. Now I've called the plumber and now he fixes with a better plaster. Okay, the pipe is leaking and now with a better plaster he is correcting the damage to the pipe. Okay, so this is secondary hemostasis. Okay, so there are two types of reactions that happen in secondary hemostasis. One is extrinsic pathway, the other one is intrinsic pathway. Okay, so extrinsic pathway is where the factor, there are 13 factors. Okay, remember there are 13 factors. Okay, so remember this, 7 to 7A conversion is extrinsic factor, whereas all the other cascade is intrinsic factor, intrinsic pathway. Okay, so in extrinsic pathway, it is 7th factor is converting to 7A, then it is converting 10 to 10A. Okay, in the same way, let us see intrinsic factor so that we can come to the common pathway and then continue it. Okay, so in intrinsic pathway, it is 12 to 12A, 11A to 11, then 9A to 9, then again here the common pathway starts where 10A to 10 is there. Okay, remember from 9A to 9A is what converts 10 to 10A. Just in the same way, 7A is what converts 10 to 10A in extrinsic pathway. It is 9A that converts intrinsic pathway, through intrinsic pathway converts 10 to 10A. Okay, this is the common pathway. To arrive at that, so it is 8A with von Willebrand factor. Von Willebrand factor also came in for primary hemostasis. Here also it is coming. Okay, with the 8A. So this cascade will continue. Okay, so now the common pathway for both of this is, so the 10A that was converted from 10 to 10A will be converting 2 to 2A. Okay, so for this to happen we require 5A. Okay, so now 2 to 2A is nothing but prothrombin converting into thrombin. Okay, now this 2A will convert 1 to 1A. 1 is nothing but fibrinogen, whereas 1A is fibrin. Where did we see fibrinogen? We also saw it in primary hemostasis, right? Where for one platelet was expressing its GP2B, for other platelet to come and join, it required fibrinogen. Okay, so in primary hemostasis also we saw fibrinogen, whereas here in the coagulation pathway also we are seeing fibrinogen. Okay, so thrombin is what converts fibrinogen to fibrin. Okay, so this is the entire coagulation pathway. Okay, are you clear with it? Please, if you are not understanding it, please one more time go to the video, and revise the video again. Okay, so with respect to what the primary hemostasis is and what is secondary hemostasis. Okay, now let us see where all we can attack and what are all the things that is happening with respect to coagulation pathway, and how can we prevent it from coagulating. Okay, so what are the factors that is happening? So so the first thing is, I told you, right, von Willebrand factor. So von Willebrand factor, if it is not there, it is affecting both the primary hemostasis and also secondary hemostasis intrinsic pathway. Secondary hemostasis also getting affected if there is von Willebrand factor disease. Okay, that's it. Then the other thing is 9 and 8. If these factors are not there, you know that the famous hematological disorder, that is hemophilia. Hemophilia will occur because of 8 factor and 9 factor. Okay, deficiency. Then coming to where we can attack this formation of fibrin, and finally see fibrin, after formation of from fibrinogen to fibrin, there is mesh. Okay, so the mesh, I told you, right, the plumber finally decides to put a mesh and permanently seal it. Okay, so this mesh is a stabilized plaster. Okay, so to break this the stabilized plaster, we require something known as plasmin. Okay, so for plasmin is not always in the blood. Okay, it is in an inactive form called plasminogen. Okay, this plasminogen will convert into plasmin. Okay, then this plasmin, it is like a hammer. Okay, so now the plumber has made a seal, and suppose I want to break that seal, so I need a hammer, right? Hammer. So this hammer is plasmin. Okay, so for plasmin to be there, we require plasminogen. Okay, so this is where TPA, transplasminogen activator, that we use in strokes and in embolectomy and in MI also we use TPS, right? So this is where we activate the plasminogen and break this mesh. Okay, so there has been thrombus which is blocking the artery, so that is where I go and hammer this entire thing and open up the blood vessel for the blood to flow. So that is where I use TPA. Okay, transplasminogen activator, tenecteplase, atiplase, and all these things. Suppose I want to inactivate. Okay, so suppose I want to inactivate this thing. So what I require is tranexamic acid. Okay, where do we use tranexamic acid? Okay, there is increased bleeding, so I want to stop that bleeding. So I want to make this mesh more stabilized. Okay, I'll call the plumber again to make this mesh more stabilized, and so for bleeding to get stopped. That is where I use tranexamic acid, which will inhibit the function of plasminogen. Plasminogen is the hammer activator. So if I inactivate the hammer activator, then there won't be any hammer, right, to destroy the plaster. So that is where I use tranexamic acid, where we use this in PPH and abnormal uterine bleeding and all we use, right? So this is the function of tranexamic acid also we saw. Then the TPS, tenecteplase, atiplase and all we saw. Okay, this is the entire coagulation pathway. The primary thing was primary hemostasis, which was mainly by platelets. The secondary coagulation, secondary hemostasis was by coagulation factors. Okay, this is the entire cascade that we'll be seeing in the hemostasis. Okay. So to measure this entire coagulation pathway, I require for some investigations. Like, so to know whether the coagulation pathway is affected or not, I need to do some investigations, right? So the investigations are bleeding time, PT and APTT. Okay, so what are these? Bleeding time is telling me the entire pathway time. Okay, primary and the secondary hemostasis. So it is around 9 to, so it is around 9 I mean sorry, 2 to 9 minutes. Okay, so the entire bleeding time is what tells me whether the bleeding time is increased. If the bleeding time has been increased, that means that there is some issue with the coagulation pathway. Okay, so this can also be used to know whether the drugs that I am giving, for example, aspirin and clopidogrel that I gave, whether it is working or not. To see that also we can use for prognosis of the medicines also we can use. Okay, so if I give the drug, it should increase the bleeding time, right? So that is how we can use these things. Then coming to PT, this measures the extrinsic pathway. Okay, extrinsic coagulation pathway, that is 7. I told you, right, 7 will be converted to 7A, and it will be converting the 10A to 10. Okay, right, sorry, 10 to 10A, right? So to measure this extrinsic pathway, whether it is working or not, I am measuring PT. Okay, remember PT as this is a short thing, right? So this is short pathway, so that is why PT. If it is a long pathway, the longer the name, APTT. So entire pathway from 12A, all these things, and will finally convert the 9 to 9A, right? So this entire thing I'll be measuring through APTT. Okay, and in remember, we can also test whether the von Willebrand factor is working or not through APTT, because I told you, right, in the 8A is required along with the von Willebrand factor to convert 9A to to require convert 9A from 10 to 10A, right? So that is why von Willebrand factor disease, this APTT is getting affected. So we'll come back to that when I'm discussing the pathologies with respect to platelets and coagulation factors. Okay, so this is all and everything, all the physiology that is required to know about the platelet coagulation. Okay, then moving on further, we'll discuss about the WBC physiology. Okay, so WBCs, as I told you, there are many cells like eosinophils, basophils, neutrophils, monocytes, and lymphocytes. All these things are there, right? So what do? So they have two kinds of a method by which they can attack. Okay, what are WBCs? These are nothing but soldiers, right? Soldiers of our body, which will go and attack the pathogens, the terrorists of the environment. Okay, so this is the main function of our WBCs. So how do they do it? They have two specialized actions. One is cell mediated. These are like special paracommandos. Okay, paracommandos. Okay, so they don't require anyone's support. They themselves can go and be killer. Okay, then humoral immunity is like other soldiers, like for example, let us take BSF, CRPF, all these things, all these people will take the help of other groups also. They'll take the help of air force, they'll take help of navy, and for example Rashtriya rifles and all, they'll take the help of other commandos, whereas para commandos require no one, right? NSGs and all require no one, like, right? So this is cell mediated immunity, whereas humoral immunity is the other thing. Okay, so let us see what are these two things. Suppose a virus infects a cell. What happens is, cell starts expressing MHC1 in its body. Okay, what is this MHC1? Okay, so there is a cell. Okay, so there is a notice board to the cell. Okay, so what is this notice board meaning? So these I told you, right, these are the soldiers. Okay, so each and every time it comes near a cell, it has to show its ID card. Okay, so what are all the functions that is happening inside you, whether all the functions are right or not. So they'll be coming for checking all the inspection and all these monocytes, lymphocytes and all will be coming for checking. Okay, so when this checking is happening, so all the cells have to put up, all the cells in our body has to put up one notice board. So this is the functioning happening. So these are the people that I have inside. Okay, so what happens is, suppose a virus is there, what happens is, this MHC class 1 and class 2 are nothing but notice board. Name of notice board is called MHC. Okay, major histocompatibility complex. Okay, is the name of it, name of the notice board. Okay, so MHC1 starts expressing in this cell, telling, this notice board is telling that I have a virus inside me. Okay, so that is when what happens is, these commandos are there, right? Para commandos, what they do is they recognize this and destroy the whole cell. Okay, so they destroy the whole cell and create a memory cell. Okay, so remembering, creating memory meaning they'll take the photo of this and keep it, so that next time someone like this uniform only or this virus only comes in, they would recognize quickly and they'll destroy it. Okay, before doing anything they'll destroy it. This is called cell mediated immunity. The cell, that is CD8 cytotoxic. Okay, this is cytotoxic CD8 cells. Okay, these are the paracommandos. CD8 are the paracommandos. Then what happens in humoral immunity is, suppose the same thing. Okay, bacteria is infecting the cell gets trapped by macrophages. What happens is, there are antigen presenting cells. Okay, so there is something called antigen presenting cells. Okay, these are dendritic cells, macrophages and the B cells. Okay, these are antigen presenting cells. Please remember all these three things, because this is a previous year question. What are the antigen presenting cells? Okay, they've asked it. Remember the same thing. So there was a cell where bacteria has attacked, so that was virus. Okay, where the cell mediated immunity occurred. Here now we are discussing about humoral immunity. Okay, here suppose a bacteria is there, MHC class 2. Okay, so wait, I'll tell you. So basically there is a bacteria inside a cell. What happens is, now the macrophage, not the paracommandos, but macrophages are also coming for inspection. So now they see that there is a bacteria. Okay, what it does is it engulfs this bacteria. Okay, this cell failed to express itself, telling that there is a bacteria inside, because the bacteria is holding a gun to the cell and telling, please do not express in your notice board that I am there. But our body is so advanced that macrophages start recognizing, oh okay, inside this cell there is a bacteria. What it does is it engulfs the entire cell including the bacteria, and this macrophage will start expressing a notice board. Okay, these macrophage and dendritic cells and B cells are the antigen presenting cells. Okay, it is trying to present something, that is why the name. Okay, so this will like project something called MHC class 2. Okay, this is the notice board. That notice board's name was MHC class 1, whereas this notice board's name is MHC class 2. Okay, so now that it is expressing itself in notice board, what it does is it calls CD4 T cells. Okay, so CD4 T cells will come. There it was CD8. I told you, right? What are these CDs? CDs are nothing but the ID cards or the roll numbers or the batch IDs that has been given to that particular soldiers. Okay, so T cells will be having CD4, CD8 and all these things. Okay, so this is the batch ID that is given to the that particular T cell. Okay, so what happens is this CD4 cell will come near this macrophage and start releasing cytokines. Okay, cytokines, interleukins, all these things are nothing but messages. Okay, so it is doing a siren sound. Okay, I'm attacked, doing a siren sound. Okay, there has been an attack. Okay, so it is announcing it. Okay, that is when immediately B cell gets activated. Okay, so this B cells come and activate and form two things. One is these B cells will recruit BSF soldiers and CRPF soldiers, that is plasma cell. Okay, these are BSF and CRPF soldiers, whereas B cell also creates itself a memory cell. Okay, so what is the memory cell is, I told you, right? Memory cell is nothing but it keeps a photograph of that particular cell and expresses to the other cells. Okay, for future reference this memory cell has been created by the B cell. Okay, now all the BSF and CRPF soldiers have come. They will be coming with the gun that is called antibodies. Okay, this is called they'll create antigen antibody complex and go for complement formation, and some of them will be phagocyte. Okay, so this is the entire cascade that happens with respect to humoral immunity. Humoral immunity is nothing but where the bacteria is being recognized by the macrophages, whereas here in cell mediated immunity it was the virus that was there, and the CD8 toxic cells, the para commandos, so basically recognized and destroyed by themselves. There was no cascade of reaction and all. Here in humoral immunity there was cascade of reaction, where there in the cell mediated it was not there. So that is the major difference. So this is how the entire process of platelets, RBCs and WBC physiology takes place. Okay, so now let us see some of the important factors of now that we have discussed the physiology. So let us see some important notable points that we are supposed to remember. Okay, so let me start with WBC, as we were discussing about WBC only. So I told you, right, these plasma cells start secreting antibodies, right? So what are the types of antibodies that our body have? Okay, remember the name gamed. Okay, gamed. So IgG, IgA, IgM, IgE and IgD. Okay, so these are the antibodies that are present in our body. Okay, so IgG, remember all these points. Okay, IgG can cross the placenta. Okay, then IgA is seen increased in saliva and colostrum. Okay, then IgM is the memory cell and also forms the complement. We discussed about memory cell and complement formation, right? So these are the IgM, wherever the memory and complement cell formation is there. So remember it is IgM. Okay, then in allergies it is IgE that is increased. Okay, so if someone comes to you with sneezing or sinusitis and allergy, so if we go give their testing, so their IgE antibodies will be increased. Okay, then coming to D, it stimulates IgM. Okay, IgM, that is memory and complement formation. So this also enhances its function. Okay, that's it. This is a supportive cell of IgM. Okay, then remember one more thing. IgM means that it is an acute reaction that is going on, whereas IgG means that it is a chronic reaction that is going on inside our body. Okay, so this is a tip that I want to give. IgM is acute, whereas IgG is chronic. Then coming to platelet functions. So remember, we had discussed in biochemistry, right? Vitamin K, there are many factors that are involved in vitamin K dependent coagulation. That is 2, 7, 9 and 10. We also had discussed this in biochemistry. So remember that 2, 7, 9 and 10. Please paste it in your sticky note. Okay, 2, 7, 9 and 10 are vitamin K dependent factors. Okay, warfarin, you know warfarin, right? Warfarin mainly acts on vitamin K dependent factors and inhibits it. Okay, so that is when there is increased bleeding. Okay, so increased blood flow is there when these factors are cut off. Okay, so there is no coagulation cascade to happen. See, both extrinsic and intrinsic pathway, both of it is being attacked by warfarin. That is why it is a very very good drug. Okay, so 7 for intrinsic extrinsic factor, whereas 9, 10 and 2 are intrinsic factors, right? So everything is getting attacked. So that is why warfarin is a very good drug. Okay, but even though it is a good drug, there are too many complications that can happen because of warfarin. One of the major thing is purple toe syndrome. Okay, this is a previous year question where we can see purple toe. Okay, purple toe can be seen in chronic warfarin users. Okay, so remember that point. Then all the other cascade or coagulation pathway is there, right? So those things are attacked by heparin and low molecular weight heparin. Okay, so remember this thing. 2, 7, 9 and 10 is attacked by warfarin, whereas the other things, the other things we didn't discuss, right? So the other 12A, 11A, all these things, and 5A, 2A, all these places the heparin can act. Okay, remember rivaroxaban and apaxaban that is given in people with post MI management after doing CABG or something like that. So we are using a rivaroxaban and apoxaban. So it directly targets on 10A. Okay, so here it directly targets, instead of all this pathway, it directly targets on 10A. So all the coagulation pathway, even though all these things is happening, final pathway of fibrin to mesh formation is not happening. So it is a direct inhibition. That is what we are targeting. So we are using this in post MI patients and all. So rivaroxaban and apaxaban, please remember this thing. So that is all and everything you need to know with respect to platelet physiology and some of the places where we start attacking these pathways. Okay, then now that we know all this physiology, let us learn about blood transfusion reactions. Okay, so these reactions takes place after or during transfusion of blood itself. There are many indications where we require blood to be transfused. For example, hemorrhage is there, or low hemoglobin is there, and or low platelet is there. So that is where we'll be transfusing blood, right? So transfusion reactions will be happening. That is why our PGs used to tell, keep on monitoring. It used to be a Sunday afternoon and we were supposed to go, but there used to be a patient where blood transfusion is required, and we used to fight amongst us with between the interns itself, that you will stay or I will stay, because these are the transfusion reactions that would have happened, or if we were not monitoring. So that is where it comes in. So let us see at what hour or what minute these particular reactions will happen. If the reaction is happening within minutes, it is going to be anaphylaxis. Okay, anaphylaxis, it is a type 1 reaction, right? Type 1 hypersensitivity. A for A. I told you to remember, right? A, B, C, D. We had discussed in general pathology, right? A, B, C, D. So it is A, type 1 hypersensitivity reaction. Then coming to, in 2 to 3 hours, if the reaction is happening, then it is going to be allergy or urticaria. Mainly allergy. We discussed right now, right? IgE will be increased. Then if it is 6 hours, it is going to be febrile non-hemolytic reaction. Okay, please remember this, febrile non-hemolytic reaction. This is the most common reaction that everyone would be having. Okay, so that is why hourly monitoring we do, right, when doing the blood transfusion, and we'll do slow blood transfusion only always, right? So because to avoid the sudden flush and sudden overload, volume overload, also we are doing it for slow transfusion. Okay, so this remember this, in 6 hours if it happens, it is going to be febrile non-hemolytic reaction, whereas again within 1 to 6 hours, if the patient is presenting with severe pulmonary edema and bilateral chest infiltrates, that is why we always try to do BP monitoring, pulse monitoring, and auscultation also they tell us to do. Okay, most of them don't tell us to do, but we are supposed to do auscultation also. All we do is BP and pulse pressure monitoring, right? So but we are supposed to do auscultation also, because there exists something called as transfusion reaction, where acute lung injury can happen. Okay, transfusion reaction of acute lung injury. Okay, so remember that way. Okay, trolley might happen within 6 hours. That is why we are supposed to monitor this, where pulmonary edema and bilateral chest infiltrates can be seen. Okay, this is a HLA type 2. Okay, not hypersensitivity type 2. This is HLA type 2. Blood transfusion reaction, remember it is we were discussing, right? Blood transfusion is gonna be type 4. Okay, type 2 reaction. Okay, so remember in that way. So less than 24 hours if the reaction is happening, it is going to be acute hemolytic. Before 6 hours it was non-hemolytic, whereas after less than 24 hours if it is happening, it is going to be acute hemolytic. It is mainly because of ABO incompatibility. ABO, all the blood groups and all we know, right? So ABO incompatibility, if it is happening, it is because of acute hemolysis that is happening. Okay, so it will be less than 24 hours. If it is more than 24 hours, then it is going to be delayed transfusion reaction. Okay, so please remember all these 6 reactions. Okay, so at what hour what reaction is happening. So this is all and everything you need to know with respect to general hematology. Okay, so now let us dive into the specifics of hematology. It is very easy. Okay, it is gonna just take a few minutes and you will be done with hematology. Okay, some 2 pages are there. We'll be done with hematology, like specifics, like in RBC what are the pathologies, at platelets, and WBC what are the pathologies. Okay, I'll make all the leukemias also very easy. Please bear with me for few minutes. So now let us dive into the specifics of RBC. Okay, so please remember that a reticulocyte, I told you, right? Reticulocyte is a precursor of RBC in particular. So it is a precursor of erythrocyte. Erythrocyte is another name of RBC. Okay, so reticulocyte, the normal count is 0.5 to 1.5 percentage, okay, in the circulation. So 0.5 to 1.5% of the circulating RBCs will be reticulocytes. Okay, this is the normal count. Okay, so retic count tells us that whether the bone marrow is working or not. Okay, so if there is a very low reticulocyte, then we can tell that the anemia that is happening because there is no RBC production at all. Okay, so that is how we can tell that RBC whether it is getting produced in enough amount, or is it because of some other issues that we are having anemia. Okay, so that is how we can suspect. So that is why reticulo count is very important. Okay, then coming to bone marrow aspiration. So bone marrow aspiration is what we do for all the suspected leukemias and all, right? So how we do is Sala's method, Jamshedi's method, and Kalaman's method. Okay, so is what the instruments that we use. Please know to differentiate between these instruments. You can go through Google and type all these names and you will get the instruments. Okay, so we all have done this in our final year Viva exams and all, right? So for practical exam it used to be there, Salas, Jamshedis and Kalman. Okay, so learn to differentiate it. They might ask it then, because they are asking all the image based and video based questions, right? So this might also come. Okay, then coming to where the bone marrow aspiration we will do is mostly ASIS, that is anterior superior iliac spine, or tibia or sternum. Okay, so the most common sites is ASIS. Okay, then coming to types of RBCs. So before knowing what are the pathologies of RBCs, let us see what are the types of RBCs that we are having in our body. Okay, so the fetal RBC will be having HbF. Okay, then in adult we have HbA1 and HbA2. Okay, so these are the types of RBC that we'll be having in our body. Okay, so fetal will be HbF, then in adult it will be HbA1 and HbA2. Okay, so fetal is nothing but two alpha subunits and two gamma subunits is what will be there in the structure. Okay, then in adults it is going to be A1 will be HbA1 will be two alpha subunits and two beta subunits, whereas A2 will be two alpha subunits and two delta subunits. Okay, so why I'm telling you this is because there is a pathology called thalassemia where all these things will be reduced or increased. Okay, so when there is increased alpha A2 and delta A2, meaning when there is increased fetal HbF, then it is gonna get called as thalassemia major. Okay, so when the alpha 2 and delta 2 is increased, then it is going to be called as thalassemia minor. See, the major RBC that is in our body is HbA1c. Okay, the Hb value that is the type of RBC that is seen in normal adult is increased amount of HbA1. Suppose if there is increased HbA2, then that is when we call it as thalassemia minor. We'll come back to thalassemia in a later discussion, but for now remember that these are the types of RBCs that will be circulating in our body. Okay, so the investigation that tells the different types of RBC, different types of hemoglobin, now we discussed, right? So these are all the hemoglobin structure we discussed about. Okay, this also tells the type of RBC that is there. Okay, so HPLC, remember the name HPLC is the investigation that we do in the suspected cases of thalassemia. Okay, so it will be easier for you to remember. Okay, now diving down to the pathologies of RBC. All the pathologies of RBC is based on the structural abnormality in RBC. RBC is a biconcave structure, right? It looks like a dumbbell. Okay, so this is how it will look like when I take a look at from side, but this is how it will look like when I take a look from above. All the RBCs, all the redness will be here. Okay, so in the middle. Okay, so this is how an RBC would look like normally. Okay, so all the RBC abnormalities is based on the abnormal structures. It would look like something like this, and all. One by one we'll discuss. Okay, these are the RBC abnormalities. So based on the shape. Based on the shape, meaning all the there is a defect in membrane proteins or membrane structure. Okay, let us see one by one how these membrane abnormalities will happen. So if there is elliptocyte abnormality, then it is the spectrin that is defected in the RBC. Where did we learn about spectrin? We learned about spectrin in the peripheral proteins. Okay, peripheral proteins in general physiology, right? I told you in the cells there will be peripheral proteins, integral proteins. Integral proteins we discussed in biochemistry, dystrophin, muscular dystrophy, Duchenne muscular dystrophy, Gower sign and all, right? So in the same way there is a other protein which is membrane protein called spectrin, which gives the structure to that particular membrane. Okay, but when there is a defect in it, there will be elliptocytes. Okay, E is S, whereas S is E. Remember in that way. Spirocytosis. Okay, hereditary spirocytosis. Remember the name, right? So it is uncarin that is defective. This is also a similar type where uncarin will be defected. Okay, a structural protein defect it is. So uncarin will be defect here. Okay, this is an hereditary disorder seen in acute hemolytic anemia. Okay, then it is G6PD where we can see hereditary spirocytosis. Here there is a test called osmotic fragility where we'll test the fragility of the RBCs after putting it into a osmotic solution. Okay, there is increased osmotic fragility in spirocytosis. So the major management would be splenectomy. Okay, because spleen is where all these RBC cells die, right? So there is increased cell death. So that is where jaundice and all these things will happen. So if we reduce the cell death, then the jaundice hemolysis and all will be reduced, and non-hemolytic jaundice, hemolytic jaundice can be reduced. So that is why the major management would be splenectomy. Okay. Here in hereditary spirocytes, we can see a bodies called Heinz bodies. Please remember this, Heinz bodies. Okay. Then coming to macrocytes. So when MCV value, the mean corpuscular volume, in RBC there is volume of blood, right? So I mean volume of all the components, right? So when there is increased volume, normally it will be 80, but if it is more than 100, it is gonna get called as macrocytes, because there is increased volume. Okay. So this happens because when there is a DNA defect, we discussed in biochemistry, right? B9 and B12, all this will cause megaloblastic. B9 and B12 will cause megaloblastic anemia because there is a DNA defect. So that is where the structure of the RBC is lost and it can increase its size. So that is what is called as megaloblastic anemia. Okay. So that is where we can see in vitamin B9 and B12 deficiency. Okay. So the clinical features that the patient is going to present to you with is knuckle hyperpigmentation. Okay. So knuckle hyperpigmentation is how the patient will be presenting you with. Then in histology, we'll be getting to see Howell-Jolly bodies. Heinz bodies is in hereditary spirocytosis, whereas Howell-Jolly bodies will be in megaloblastic anemia. Then coming to target cells. So these are how the target cell would look like. Okay. So that is all, everything you need to know. Need not know more about target cell. Okay. Then coming to sickle cell anemia, there is a gene defect, that is GLU to VAL. Okay. Glutamine to valine is what the gene defect is. Okay. So this is a translocation that is taking place in formation of a gene. So if glutamine is replaced by valine, that is when the sickle cell anemia occurs. Okay. So here also we can see Howell-Jolly bodies just like megaloblastic anemia. Okay. So Howell-Jolly bodies can be seen in both of this. Okay. Remember that here autosplenectomy is happening because all the cell shape is sickle. So this will go and destroy all the endothelium and all the structures in the spleen. So that is why autosplenectomy is happening, where spleen's size is getting reduced because of all the fibrosis that is happening because of destruction of these because of destruction of the spleen from this sickle. Okay. So how do you manage is by introducing hydroxyurea. Hydroxyurea is what is being used for sickle cell management. Okay. Then coming to auto agglutination, it is autoimmune hemolytic anemia. Okay. So remember this is very famous question in our entrance exam. Autoimmune hemolytic anemia, examiners have been very interested in asking this question because there are two types and all of us will get confused because from these two types. Remember only these points that I'm going to tell you and you will be sorted for your exams. In autoimmune hemolytic anemia, there are two types. One is warm type, the other one is cold type. Warm type will happen because of SLE. The cold type is because of EBV and mycoplasma. Okay, this is an autoimmune disease, whereas these viruses and all the microorganisms induced thing is called cold IHA. Okay, so remember in that way and it will be easy for you. Autoimmune is a chronic condition, right? So that is why IgG will be increased here, whereas these infections will be acute, right? So remember IgM. Okay, so that is how you can remember. Then when it comes to the treatment of it, steroids is the mainstay of treatment for warm AIHA, whereas reduction of cold environment is the mainstay of treatment for cold AIHA. Okay, that's it. Then the major the treatment that has been developed for this is rituximab. Okay, so rituximab is the major drug that has been developed for this. Both of this will be working by the same drug only. Okay, so AHA can be treated by rituximab. Okay, remember in that way and it will be easier. Okay, so AHA should go to your sticky note. Okay, then coming to spur cells, it is gonna be acanthocytes. What is acanthocytes? We discussed the same thing in biochemistry, right? The last point that we discussed was A beta lipoproteinemia, where ADEK deficiency is there because there is no fat absorption. So fat absorption is not there, meaning uh, fat absorption vitamins are also absent. So that is when, if vitamin E is antioxidant, if the antioxidant is not there, then there is increased oxidation stress in the RBCs. So so RBCs will have a specific shape called acanthocytes. Okay, so this is how you can remember it. Then coming to teardrop cells, so RBC would look like a teardrop. Okay, this is how the RBC would look like. So this we can see in myelofibrosis. Okay, myelofibrosis is nothing but bone marrow fibrosis. Myelo is nothing but bone marrow. So in bone marrow fibrosis, we can see teardrop RBCs. Then coming to helmet cells, this is how an helmet would look like. Okay, so we all would have seen Harry Potter, right? So in Harry Potter, this is how the cap that decides which house we are going to go into is look like, right? So this is the helmet. Okay, then so these are called helmet cells are also called as schistocytes. Where we can get to see this is in angiopathic hemolytic anemia. Okay, so there are two types of angiopathic hemolytic anemia. One is micro vessels and macro vessel based hemolytic anemia. Okay, micro vessels is HUS, TTP, HELP syndrome, and DIC. Whereas vasculature is prosthetic valves. Okay, so in prosthetic valves, if this is happening and we are seeing helmet cells, then it is gonna be macro cell based angiopathic hemolytic anemia. Whereas if all these syndromes that we discussed, each of these syndromes I'll discuss further going on, but remember these micro vessel diseases is what causes the helmet cells. Okay, then coming to bite cells, the same thing we discussed, right? The Heinz bodies in hereditary spherocytosis is mainly because of oxidative stress, G6PD deficiency. G6PD is an antioxidant. Just like vitamin E, this is also an antioxidant. Okay, so reduces the stress on the RBC. If there is G6PD deficiency, then it is going to cause oxidative stress and will lead to bite cells. Okay, it looks like an apple bitten. Okay, it looks like a bitten here over here, right? So this is what we can see with respect to G6PD deficiency. Okay, Heinz bodies can also be seen in hereditary spherocytosis. Okay, so remember that. Then coming to basophilic stippling, so in sideroblastic anemia, okay, in sideroblastic anemia and if heme synthesis is affected, this is where we will see basophilic stippling, where for example this is an RBC, we'll be seeing some basophilic stipplings. Okay, so basophilic stipplings will be there. This is because there is affected heme synthesis. I told you, right? In formation of heme, in the synthesis of heme, the ferrochelatase and all these things are important, but lead damages this ferrochelatase and will inhibit the formation of heme. So this is the same thing. Okay, what happens is lead destroys this and heme will start accumulating inside the RBC without forming a proper structure. So that is why this basophilic stippling all will be seen. Okay, this is known as sideroblastic anemia because of lead infestation, or it is also called heme synthesis defect. Okay, where I told you, right, heme or Fe will be deposited in RBCs without a proper structure. Okay, then coming to PNH, that is the very important. This should go into your sticky note, that is paroxysmal nocturnal hemoglobinuria. Okay, paroxysmal, meaning of paroxysmal is leaving and coming. Okay, so it is not always or continuously, but it is going and coming meaning, so it is nothing but paroxysmal. Okay, nocturnal meaning night, hemoglobinuria. Okay, there is increased hemoglobinuria in the night. Why does this happen? Let us see. Okay, in RBCs there is something known as CD58 and CD59 which protects the membrane of the RBC, but if there is a defect in that membrane protection, then it is gonna go and form a complement mediated lysis. Okay, so there is no protection from CD55 and CD59. I told you, right, these are the batch numbers. So if there is no protection of RBC membranes, then it is gonna cause destruction by some of the antibodies. So if there is a destruction, so this leads to hemoglobinuria, meaning there is lysis of RBC and hemoglobin, there is increased hemoglobin and hemoglobin urea is there. Okay, so this happens increased at night because in night there is carbon dioxide increase and acidosis is there. Acidosis will cause increase in lysis of RBC. Okay, so that is where we'll get to see PNH in the night. Okay, so that's it. So the major treatment of choice would be eculizumab. Okay, so this should go into your sticky note. Okay, so eculizumab also should go into your sticky note, just like just like we discussed about AIH, where it was rituximab. Okay, so in that way, so entire thing, both AIHA and PNH should go to your sticky note. The rest of the other thing you will remember. Okay, so need not worry about that. Just go once and revise it, and you will be done with it. Okay. Then, now that we are done with all the structural abnormalities, let us know in little about anemia. Okay, because they have been interested in asking about iron deficiency anemia. So let us see what is this anemia and what is thalassemia. Okay, so there are three types of anemia: microcytic anemia, normocytic anemia, macrocytic anemia. Microcytic meaning the RBCs will be small, whereas normocytic meaning RBCs will be in the normal size and still the anemia will be occurring. Macrocytosis meaning the RBC size has been increased, that is why enough hemoglobin is not being carried, so that is why anemia is happening. Okay, so microcytic anemia is of majorly because of two things, that is IDA deficiency, that is iron deficiency anemia, and the one more thing is thalassemia. Okay, so iron deficiency anemia, you definitely know it because there is low intake of iron, or some other times it may be because of low absorption of iron that is happening. Okay, so that you got you know. Okay, so from final year also you got to know. But thalassemia we have not studied much, so that is why let me tell you about thalassemia here. Iron deficiency anemia, you know everything about it, the lab values also you will be knowing. Okay, so that is why I'm not going into it, whatever the things that you know, right, so that I'm not discussing here. Okay, so let us go into thalassemia without wasting any time. So thalassemia, I told you, right, there is two types, minor and major. Okay, minor is because when there is HbA2, the adult type of hemoglobin, if it is raised, then it is going to be minor type of thalassemia, whereas if it is the fetal type that is increased, then it is going to be major type. Okay, HbA1, you know that, right, HbA1c, that we do the concentration of glucose that is present in the cell. Based on this is what we diagnose the type 2 diabetes mellitus, right, based on HbA1c value. This is the normal hemoglobin, but A2 should not be increased. A1 if it increases, it is well and good, but A2 if it increases, it is going to cause minor thalassemia. And if it is HbF that is increased, it was supposed to be only in fetus, but if it is increasing in adulthood also, then it is going to cause something known as thalassemia major. That's it. Then there is alpha thalassemia and beta thalassemia. Okay, thalassemia is minor and major, but there are other two types, that is alpha thalassemia, which is minor and major, where alpha the globulin chain is affected. It is also having minor and major. Minor meaning we were telling, right, A2 is increased, whereas major meaning HbF is increased. HbF, here the alpha chain is affected. Okay, here also the alpha chain is affected. Okay, that's it. Then beta thalassemia is where the beta chain is getting affected. Okay, B2 is beta chain is getting affected. Here it is gonna be minor and major. Okay, so the chromosomes involved here is chromosome 16 in alpha thalassemia, whereas chromosome 11 in beta thalassemia. That's it. Okay, how we are going to diagnose is by seeing the facial features itself, we can diagnose the patient. So he's gonna have chipmunk facies. Okay, so why is this? Because there is increased extramedullary hematopoiesis. Okay, hematopoiesis is increased amount of cell formation, right? So because there is not enough hemoglobin to be carried, so and anemia is happening, what our body thinks is, okay, so I probably I need more hemoglobin. So that is why extramedullary, okay, not only in the long bones, but also in our skull bones and facial bones, all these the bone marrow is there, right? So all these bone marrows will start producing hemoglobin, or I mean sorry, RBCs. So that is why hematopoiesis starts increasing, and the facial features also is gonna get changed. Okay, so because bone marrow function has been increased, so that is where we can see the particular skull X-ray, and in the mediastinum also we can see that hematopoiesis is happening. Okay, this is the pathognomic of thalassemia major. So major thing I want you to remember is, please let this also go into your sticky note. This is called Mentzer index. Okay, so based on this Mentzer index only, we are going to decide whether the anemia that is happening, the microcytic anemia that we diagnosed, was because of iron deficiency anemia, or is it because of thalassemia. Okay, so Mentzer index is nothing but MCV by RBC. Okay, MCV by RBC count. Okay, where if it is more than 13, it is going to be iron deficiency anemia, where if it is less than 13, it is going to be thalassemia. I told you, right, RBC count will be increasing because extramedullary hematopoiesis is happening. So that is why as the denominator increases, it is going to be lower than 13, whereas in iron deficiency anemia there is no increase in hemoglobin, okay, or RBC count. It is going to be the mean corpuscular volume that will be problem, right? So that is why there will be increased Mentzer index in IDA. Okay, so this is what I want you guys to remember with respect to RBC pathologies. We saw what is the basics of RBC, then we saw the abnormalities in the cell structure of RBC, then it was anemia, that is iron deficiency anemia, and thalassemia that we discussed. Okay, these are the major RBC pathologies that you guys should be aware of. So guys, now let us go on to the platelet and coagulation pathway pathologies. Okay, so we have discussed that primary hemostasis is by platelets, whereas the secondary hemostasis is by coagulation factor. Okay, so remember this extra point, okay, for your clinical practice. Okay, so in arteries, it is going to be platelets that would cause the coagulation more than coagulation factor, because in arteries what happens is there is increased pressure and flow, right? So there won't be enough time for the coagulation factor to start acting on. Okay, so that is why platelets are the ones that are primary in causing the hemostasis, whereas in veins it is going to be the coagulation factors more than platelets that would cause the coagulation, because in veins there is not enough pressure, so coagulation factors have enough time to act on, right? So that is why in veins it is going to be the coagulation factors that are increased. So that is why I'm telling you this is because when we try to attack the arteries, like for example there is a artery pathology or coagulation or thrombus in the artery, we will be using antiplatelet drugs rather than anticoagulation drugs, right? Warfarin, heparin and all, we tend to use it in veins more rather than in arteries. So this is what the mechanism behind it. Okay, so antiplatelet drugs is what we use in arteries, whereas anticoagulants is what we use for vein pathologies. Okay, so this is how you have to remember with regards to how we use these anticoagulants. Okay, now let us dive into the pathologies of platelets. Okay, so we'll divide again those things into platelet disorders and coagulation disorders and combined disorders. Okay, where both the platelets and coagulation disorder is affected. So now starting with platelet disorder, so the main clinical feature that they are gonna come up with is petechiae. Okay, petechiae and purpura. Okay, so there will be bleeding. Okay, bleeding will be there. So investigation of choice is bleeding time, right? Bleeding time, anyway, it is gonna be same in primary hemostasis and in secondary hemostasis, but to be specific for platelet disorders, it is gonna be the platelet count that we are gonna take. Okay, the investigation. Okay, so now let us see, if platelet is reduced, what is the pathology, and if the platelet is normal, then what is the pathology. So if the platelet is normal and the primary hemostasis is affected, then it is going to be the Glanzmann pathology that can be seen. Okay, so it is because of GP2B that is affected. Okay, this is Glanzmann pathology. So now let us see, if the platelet production is reduced, then what are the pathologies. Okay, so remember that if immature platelets are more than 6%, then we take it as platelet count is reduced. Okay, so remember in that way. Now ITP, immune thrombocytic purpura, meaning there is autoimmune lysis of platelets. So in immune thrombocytic purpura, it is because of the anti GP2B, the GP2B is getting affected. See, here also it is the same, but here the platelet count was normal, but here the platelet count has been reduced because it is because of the antibody that has been against this receptor. Okay, so the major etiology behind this to be getting triggered is SLE, HIV, and hepatitis C. Okay, so remember these etiologies. So the pathognomic would be the giant platelets that we can see in the histological slides. Okay, so what is the treatment of this? It is an autoimmune reaction, so that is why it is going to be steroids and IV immunoglobulins. Okay, so again here also it is going to be rituximab. Okay, where else would we see rituximab? It was in AIHA, autoimmune hemolytic anemia, right? So it is also autoimmune, so remember in that way, rituximab is for immune thrombocytic purpura. And Bernard-Solier syndrome we discussed already, right? Anti-GP1B. Okay, anti-GP1B would be Bernard-Solier syndrome. Okay, that's it. Then now let us move on to coagulation disorder, where the clinical feature will be bleeding. Okay, here in platelet disorders it was petechiae or purpura, so that is why, see, in dengue we'll get to see petechiae and purpura right in the beginning, but in the later parts only we'll get to see bleeding, right? So in later parts, because coagulation pathway is also affected, because there is no enough platelets for primary hemostasis, where will the coagulation factors act on, right? So that is why we'll see bleeding in the later stages, whereas petechiae and purpura in the early stage itself we'll get to see, right? So remember this even for your clinical practice also. Okay, now there it was bleeding time that we were doing the investigation of choice was, and we were seeing the platelet count. Okay, but here in coagulation disorder it is gonna be PT and APTT that we are gonna see for investigation. Okay, if PT is affected, I told you, right, extrinsic pathway will be affected, whereas APTT is affected, then it is gonna be intrinsic pathway that is affected. If both PT and APTT is affected, then there is a problem with some other thing. Okay, let us see what that some other things and all are. Okay, so if platelet count or platelet time is increased, prothrombin time is increased, then it is because of factor 7 that is getting affected. It can be seen in warfarin toxicity. Okay, so if there is a prothrombin time that is increased, then it is gonna be suspect warfarin toxicity if the patient gives an history of warfarin use. Okay, then If the APTT is increased, then it is going to be intrinsic pathway that is getting the affection. So that is why if it is adult, it is going to be hemophilia, whereas if it is if it is a child, it is going to be hemophilia, whereas if it is an adult, it is going to be APLA syndrome. APLA syndrome, more about this I'll discuss in obstetrics. Okay, so remember, it is APLA syndrome, which can be seen in adults. Okay, so remember in that way. So now, if both APTT and PT are affected, then what is the thing? If both are normal and even then there is a coagulation issue, then factor 13 is what is affected. Okay, so where does factor 13 come in? So let me go back to our chart or the flow chart again. Okay, so remember, here I told you, right, factor 30, here the fibrin was forming a mesh. Okay, so the plumber came and he formed a mesh, right? So to stabilize that mesh, there we required something known as factor 13. Okay, so this is the final thing that is required for the stabilization of the mesh that was put by the plumber for the leakage. Okay, so if there is a factor 13 defect, then it is gonna not show up in PT and APTT, because PT and APTT both will be normal here. Okay, there is no coagulation pathway that is getting affected. It is the factor 13, the stabilizer, that is getting affected. Where can we see this? It can be seen in umbilical stump bleed. Okay, so if factor 13 is defect, then after the delivery of the baby, when we are doing the umbilical cord cutting, so after umbilical cord is cut, there is increased bleeding from the umbilicus. Okay, so suddenly it should stop, but there is increased bleeding from the umbilical stump, then we can suspect that it is a factor 13 defect that is happening. Okay, so now if the PT and APTT both are increased, then it is gonna be fibrinogen that is decreased. Okay, so this can be seen in DIC. Okay, so in DIC we can suspect APTT and PT to be increased. Okay, so now you got to know all the pathologies with respect to platelet disorders and coagulation disorders, right? So now, if both of this coagulation disorder and the platelet disorder is present, both platelets and coagulation is affected, so it is going to be von Willebrand disease. Remember, right? So I told you, right, von Willebrand factor was required for primary hemostasis also, then it is also required for secondary hemostasis, the 8A factor that we told, right? Here in primary it was von Willebrand factor that was released by WP bodies, we discussed, right? So this was the first step in primary hemostasis, right? So this was the last step in secondary hemostasis. So both of this is getting affected. So here, so platelet is getting affected, here the coagulation pathway is getting affected. Okay, so that is why both combined disorder, here bleeding time, PT, APTT, everything is raised. Okay, so that is why it is called as combined disorder. Von Willebrand disease is a combined disorder of both platelet and coagulation factors. Okay, remember in that way and it will be easy for you. Okay, some of the miscellaneous stuff I'll teach you. Okay, one is thrombotic thrombocytic purpura, TTP. Okay, so it is because of ADMATS13 enzyme deficiency. Okay, ADMATS13 enzyme deficiency, where there is increased amount of ultra large von Willebrand factor. Okay, there is increased amount of ultra large von Willebrand factor. See, I discussed, right, WP bodies was releasing von Willebrand factor. Suppose if there is ultra large von Willebrand factor, what happens is these von Willebrand factors, the ultra large ones, will be degraded into small cells. Okay, so these von Willebrand factors, what happens is it leads to aggregation of platelets, especially in the microvasculature. These ultra large cells gets divided into small von Willebrand factors. So that is why there is increased amount of thrombosis. Okay, so thrombosis can increase in a larger amount, that too in small microvasculatures these factors can come and increased thrombosis can happen. That is why it is known as thrombotic thrombocytic purpura. Okay, the clinical feature of this is neurologic symptoms and fever will be there. Okay, so because small vasculatures, where can we see more of it, the small vasculature in the brain, right? So brain is getting affected, so that is why we will get neurological neurological symptoms. Whereas these ultra large 1 milliband fracture, as it is getting degraded into smaller pieces, that is why we'll get to see fever. Okay, so remember these two clinical features with respect to TTP. Okay, then coming to hemolytic uremic syndrome, HUS, we discussed this in microbiology, right? I told you, right? E. coli, that is O157H7. The H, I told you it was flagella. I told you to remember. It is gonna release something known as Shiga toxin. This Shiga toxin will lead to hemolytic uremic syndrome. Okay, so what is the clinical feature? It is gonna be bloody diarrhea, because it is E. coli. E. coli causes GIT damage. So that is where bloody diarrhea is there. So that is the clinical feature of HUS. Okay, there is a triad between both of these things. Okay, both TTP and HUS share a triad of symptoms. Other than their specific symptoms, it is gonna share a triad. So what is the triad? It is gonna be thrombocytopenia, because all the platelets are getting used. So it is gonna be thrombocytopenia. Hemolysis, I told you, right? In both of this there is hemolysis. So because of hemolysis and thrombocytopenia and the thrombi that is being formed in microvasculatures, there is microangiopathy, which also can damage our kidneys. So that is why it can lead to acute kidney injury. Acute kidney injury, one of the major etiologies is TTP and HUS. Okay, so whenever we suspect AKI, we always rule out these two things also. Okay, when we'll go to nephrology, we'll discuss more about it. Okay, so these are the pathologies that can be seen in with respect to platelets and coagulation. So now the major thing, the leukemias and lymphomas, your favorite topic with respect to WBC, we'll see. Okay, so let us see what are these leukemias and lymphomas. Normally matured cells enter the blood, right? From bone marrow, all the hematopoiesis will happen inside the bone marrow itself and release whatever the matured cells are there. Like think it as schools. Okay, schools or the military camps, these blood bone marrows are. So it will release only the trained soldiers only, right? So if there is infiltration of untrained soldiers, that is when the issue happens, right? They won't be trained enough and they will start charging on our own cells also, and there is immature action by these cells. Okay, because they are not trained properly, they don't know what to do, right? So that is when the issues happen. Okay, so WBCs are our soldiers, so that is why I'm telling you trained and untrained military personnels. Okay, so now in blood, if the immature or the blast cells enters, that is when we see leukemia. Okay, so leukemia is where when the immature or blast cells enter the blood. Okay, whereas in lymphoid organs, if there is immature and blast cells are there, that is when we say it as lymphomas. Okay, if it is in the blood, it is going to be leukemia, whereas if it is in the lymph nodes, it is going to be lymphomas. Okay, so let us see what are the types of leukemia. Okay, in leukemia, the major thing that is important is the myeloid leukemia and the lymphoid leukemia. Myeloid progenitor cells, remember, right? I was telling you all the WBCs that were eosinophils, basophils, neutrophils and the monocytes. These are myeloid from the myeloid progenitor cells, whereas the B cells and the T cells, the plasma cells, all these things that are called lymphocytes in general are from the lymphoid progenitor cells. Okay, so when there is increased myeloid progenitor cell activity, these myeloid leukemias will occur. Okay, so those are of two types. One is acute myeloid leukemia, the other one is chronic myeloid leukemia. Okay, here in acute myeloid leukemia, AML, famously known as, there is increased blast cells, right? So I told you, right, in hematopoiesis, wait, just let me go back to hematopoiesis. Here we were discussing about all the myeloblasts and monoblasts, right? So if these blast cells are increased in the blood, then it is gonna be AML. Okay, acute myeloid leukemia is where the blast cells are increased. Okay, if it is the matured and immature cells that are coming in, not the blasts, but the matured and immature cells that are coming into the blood, then it is going to be chronic myeloid leukemia. Okay, if it is blast cells, then it is going to be acute cells, where acute myeloid leukemia. Whereas if it is other mature and immature cells and increased number of these mature and immature cells, then it is going to be chronic myeloid leukemia. Okay, so acute myeloid leukemia will be most commonly seen in 15 to 40-year-olds. Okay, so if in the question 15 and 40-year-old is there, so please suspect these things. AML. If it is more than 50 years old, suspect chronic myeloid leukemia. In the question itself, they'll be telling you, okay, about the age of the patient. So that is when you will be start thinking about whether it is chronic or acute myeloid leukemia. Other than that, they'll also give you the features of there is increased number of blast cells and there is increased number of other types of mature and immature cells. That is how you decide the diagnosis. Okay, remember, when I take a histological slide of chronic myeloid leukemia, all the cells will be there. Okay, so lymphocytes, not the lymphocytes, all the basophils, neutrophils, all the cells will be there. Okay, apart from the blast cells, it is going to be all these cells will be there. So it looks like a garden party or dressed in different cloths, right? So all this will be dressed in a different cloths. So that is why the name garden party appearance. Okay, definitely this is a famous thing that they would call as garden party. So if garden party thing is given, then you suspect chronic myeloid leukemia. Okay, in specific of all these cells, if the basophils are increased, then it is going to be CML. Okay, so if the blast cells are increased, then it is going to be AML. If the basophil cells are increased compared to other cells, it is going to be chronic myeloid leukemia. Okay, so this is with respect to myeloid leukemia. Then coming to lymphoid leukemias, again same thing, acute lymphoid leukemia and chronic lymphoid leukemia. Acute, there also it was blast cells, meaning immature cells. Here also the same thing. Okay, so the pre T cells and B cells. Okay, so immature cells, pre-B cells and T cells, the immature cells. So that is why acute lymphoid leukemia. Here, the major and the majority of the patients that are affected are kids. Okay, so a child comes with certain features of leukemia, they'll give in the question. So that is when you'll go for ALL. Okay, so child is there, please rule out this and this. So it is definitely ALL. Okay, so in the question itself you can rule out. So this is how you diagnose AML and ALL. Okay, then coming to chronic lymphoid leukemia, in very old patient, a very old 80-year-old or 70-year-old, they'll give. Okay, so if it is that in the question, it is definitely chronic lymphoid leukemia, where the abnormal lymphocytes are present in the blood. Okay, here in ALL it was immature cells, immature lymphocytes, whereas in chronic it is going to be abnormal lymphocytes that will be present in the blood. So this is how you will diagnose the leukemias. So leukemias are done. Okay, so I want you guys to study about the CD markers. Okay, CD markers, the ID that I told you, right? The batch number or the roll number that the scientists have given to all these cells. So please go and study all these CD markers and also all the genes that are affected with respect to these leukemias. Okay, so please study yourself or paste it in a this one, the sticky note about all these genes that are affected in the in the myeloid and lymphoid leukemias. Okay, so let us move on to lymphomas. I told you, right, if it was blood affecting blood that is getting affected, then it is going to be leukemia. Whereas if it is the lymph node that is getting affected, it is going to be lymphoma. Okay, so there are two types of lymphomas. One is Hodgkin lymphoma, the other one is non-Hodgkin lymphoma. Okay, Hodgkin lymphoma is where one certain particular cell called red Steinberg cell is what is getting affected. Okay, only these cells are getting affected. Okay, this particular cell, this is also a lymphocyte or a WBC cell, but it has undergone malignant turnover and is causing cancer. Okay, so only the Reed-Steinberg cell is affected. This cell in particular would look like an owl. Okay, owl eye. Okay, so that is why Reed-Steinberg cell are also called as owl-eyed cell. Okay, so in Hodgkin lymphoma, this is very pathognomic. Okay, this we have been learning since our second year also. Okay, so if suspected of Hodgkin lymphoma, this can be seen where only the Reed-Steinberg cell is affected and only that particular lymph node will be affected. Okay, remember, it is like a kid with the enlarged one single lymph node is given in the history, then please suspect it is Hodgkin lymphoma. Okay, that is why it is a localized disease. It won't spread to another lymph nodes. It is very rare that it is gonna spread, and it is surgically resectable. Okay, so that is why it is a safe kind of lymphoma. So it is gonna be localized. Okay, whereas in non-Hodgkin lymphoma, here all the cells are malignant. Okay, all the cells that is present in the lymph node is malignant. Okay, so that is why it can spread and cause multiple lymph node metastasis. Okay, so this is very dangerous. There are many subtypes of Hodgkin lymphoma like follicular, nodular, and all these things are there in non-Hodgkin lymphoma. Please go through that. Just one single point of each thing you should know about it. Okay, there are many types. That is what I was telling. There are many types in non-Hodgkin lymphoma. In Hodgkin, only the RS cells is affected. That is Reed-Steinberg cell is affected. Whereas in non-Hodgkin lymphoma, all the cells, WBC cells are affected and is causing multiple node involvement. Okay, this is all and everything that you guys need to know with respect to hematology. Okay, I've discussed all the physiologies, all the RBC pathologies, the platelet and coagulation pathologies, and the WBC leukemias and lymphomas. Okay, thank you.